Hi, everyone, and welcome back to another week of the Bulletproof Hygiene podcast. We are so thankful that you're with us today, and we, of course, have a really important topic picked out and planned out that we know is relevant in our operatories every single day. And we hope that you find some tidbits that you can implement and start considering in your daily practice. And today's topic is about our role in our patients' joint health. So, of course, we're talking about joint health regarding inflammation, autoimmune diseases, joint replacement, anything that affects what we are doing with our patients, all the correlations between perio and joint health for our patients. So that's what we're covering today. So it's Charissa and I, we're going to jump right in. And we're going to share a little bit from personal experience, share a couple of case studies at the end. But a lot of this is just research and kind of the latest and greatest regarding how perio and joint health are so related and interrelated, how they influence one another, what causes these things to be influenced, and how we can kind of tailor our clinical treatment to minimize inflammation and minimize autoimmune triggers for our patients. So as healthcare practitioners, we know that our aim is to treat whole people, not just our mouths. We know that what we evaluate, educate, and treat will impact positively or negatively our patients' quality of life, as well as their overall morbidity load. Today, we're reviewing what research says about the correlation between joint health and oral pathogens, how they're connected, what impacts the onset of RA, and how we can intervene clinically to reduce our patients' risk for suffering with debilitating autoimmune diseases such as RA. We're all familiar with patients coming to us for clearance for joint replacement, and this speaks volumes to the connection between oral infections and joint infections. It is our duty to encourage our patients to delay elective prosthetic joint surgery until oral infections have been stabilized. And Charissa has a personal experience that she wants to share here.
And I mean, honestly, I've seen a couple of patients through the years that have come with their clearance letters. They're either, having a knee replacement or a hip replacement or shoulder surgery, something like that. And so they're coming with their clearance letter. And this has happened to me a couple of times where they bring in their letter and we get in there and we do the evaluation and there's bleeding and inflammation and active infection. And, I've had two patients that got really frustrated with me actually, because I said, honestly, I'm not sure we've got to get this under control before you go through with the surgery. Mm-hmm. And they were frustrated because, they'd already scheduled their surgery and they had planned all around this. And, this was just kind of in their brain, this was like the last little checkoff box before the surgery, not really realizing what an impact it could have. So it was one of those, I know they were really frustrated with the doctor and I on the front end, as we said, nope, this is active infection. We've got to get this treated and under control before you move forward. And, I feel bad on that side because I know that they're frustrated and they had planned, but I also know that when I send the letter of clearance back and say, I'm not giving clearance because of this, this, and this, then I know their surgeon is going to tell them the same thing. So I know it's not just a one-sided thing. And it's nobody likes to feel like somebody is unhappy with you. But at the same time, you also have to step back. And this is the bigger picture of this patient's health, because here's the reality is if patients move forward with a joint replacement and they have an active oral infection, the likelihood of those pathogens infecting that new joint are very high. And if that new joint does get infected, they're looking at either, a tremendous amount of antibiotic therapy. A lot of times it's a secondary surgery. So, we sometimes might be hesitant to say, yeah, you maybe should wait for this just because the patient is frustrated, but you're really actually helping ensure that they have a much better outcome in the long term. And it's much less of an inconvenience to just delay the surgery once versus having to go through that process again, or really have a long-term problem, where they're not healing.
Right.
And, every year US surgeons replace more than 1 million knees, hips, shoulders, elbows, and ankles. And of those, knees and hips are the most common. And a Mayo Clinic study done back in 2014 reported some 4.7 million artificial knees and 2.5 million artificial hips among US adults. And that was back in 2014. So we know that's exponentially more at this point. And I'll say, honestly, we're here wrapping up 2020. I had many patients this year coming to tell me that they're getting ready to, pursue a new joint. So I know these numbers are rising exponentially. So, you know, I just want to stop for a second, and you guys know that I get super geeky on this whole oral systemic connection thing, and I can't ignore it, but this is one of those times where, and I'm just going to speak candidly, that if we as hygienists are just kind of bulldozing through and not taking the time and just knowing we have that next patient, we just got to get this patient done, and we're participating in bloody prophies, this is where we can really set our patients up for failure, not just from an oral standpoint. And I say this as we kind of start to delve into the whole arthritis conversation, because we're going to talk about some studies here that have shown, you know, that some of these oral pathogens have been shown to initiate arthritis in joints, not just compound what's already there, which does happen, but actually initiate. That's a big weight that we have. So I want us to be mindful again that what we're doing on our operatories every day, you know, is a big deal, and it has a big impact. And so as we roll into the rheumatoid arthritis side of things, or just arthritis in general, according to the CDC, and this was from this year, 2020, about 1 in 4 US adults, which is 23.7%, or 58.5 million people, have doctor diagnosed arthritis. It is more common in women compared to men. Women, it's about 23.5%. Men, it's about 18.1%. It's more common among patients with fair to poor health compared with those who have excellent or very good health, and less common among adults who meet physical activity recommendations compared with adults who are insufficiently active or inactive. And as we know, arthritis prevalence increases with age. It is estimated that by the year 2040, 78 million US adults will have arthritis. And that was published by Arthritis and Rheumatology back in 2016. And honestly, at this point, experts aren't sure which health issue is the chicken and which is the egg. Back in 2008, German research published in the Journal of Periodontology showed that people with RA had 8 times the odds of developing gum disease as compared with people without RA. And study after study has brought more clarity to the connection. Research from the University of Louisville in Kentucky, published in September of 2013 in the Journal of PLOS Pathogens, found that the bacterium that causes periodontal disease, we're familiar with it, Mr. PG, increases the severity of rheumatoid arthritis, leads to an earlier onset of the disease, and causes symptoms to progress more quickly.
Right, so there's a great review from a journal called Current Opinion of Rheumatology. This was published in 2019, and it says, in the last decades, our knowledge about the pathogenesis of rheumatoid arthritis substantially changed. Several evidences demonstrated that the initial production of autoantibodies is not localized in the joint, rather in other immunological active sites. A central role seems to be played by periodontal disease, in particular, because of the ability of P. gingivalis to induce citrullination. Oh my God, I'm stumbling here. To induce citrullination. The post-translational modification leading to the production of anti-citrullinated protein and peptide antibodies, the most sensitive and specific rheumatoid arthritis biomarker. So I'm going to explain what citrullination is a little bit lower down, but it creates the marker that doctors look for when determining if a person has RA. The pathogenic role of P. gingivalis has been demonstrated in mouse models in which arthritis was either triggered or worsened in infected animals. P. gingivalis showed its detrimental role not only by inducing citrullination, but also by means of other key mechanisms, including induction of netosis, osteoclastogenesis, and T17 pro-inflammatory response leading to bone damage and systemic inflammation. In rheumatoid arthritis and in other autoimmune diseases, such as psoriatic arthritis, systemic lupus, and Sjogren's syndrome, autoantibodies often attack citrullinated proteins. So autoantibodies often attack the citrullinated proteins. The presence of anti-citrullinated protein antibody is a standard test for rheumatoid arthritis, and it is associated with more severe disease. Citrullinated proteins are also found in the cellular debris accompanying the destruction of cells in Alzheimer's disease and after smoking cigarettes. So citrullination seems to be part of the mechanism that stimulates the immune system in autoimmune disease. However, citrullinated proteins can also be found in a healthy colon mucosa. So this is citrullination explained, and it's important that we kind of understand why this matters. So citrullination or deamination is the conversion of the amino acid arginine in a protein into the amino acid citrulline. Citrullination controls the expression of genes, particularly in a developing embryo. The immune system often attacks citrullinated proteins, leading to autoimmune diseases such as rheumatoid arthritis and multiple sclerosis. Citrulline is not one of the 20 standard amino acids encoded by DNA in the genetic code. Instead, it is the result of a post-translational modification. Citrullination is distinct from the formation of the free amino acid citrulline as the part of the urea cycle or as a byproduct of enzymes of the nitric oxide synthase family. Arginine is positively charged at a neutral pH, whereas citrulline is uncharged. This increases the hydrophobicity of the protein, leading to changes in protein folding. Therefore, citrullination can change the structure and function of proteins. So basically, citrullination is the change of arginine into citrulline, and your body attacks citrulline basically. So it creates like this autoimmune, like inflammatory response. So it creates like some of the markers that doctors look for when determining if a person has RA. So P. gingivalis has a lot to do with that process. Like the presence of P. gingivalis has a lot to do with that process. So I thought that was very interesting. Also, from another journal, I have like a small excerpt from another journal talking about periobacteria a little bit more specifically. It's the Journal of Oral Microbiology, and it says, there have been recent reports suggesting a significant association between RA and PD. The hypothesis that RA is an infectious disease has been postulated for over 70 years, which I did not know. It is proposed that RA patients have direct contact with microorganisms and their virulent factors, which activate an immune response in the synovial membrane with the accumulation of immunocompetent T and B cells. This reaction is mediated by neutrophils, monocytes, and lymphocytes, leading to the release of proteinases, cytokines, and prostaglandins that stimulate osteoclast activity and bone resorption. While some reports have indicated that an infectious agent is in a susceptible host could be one possible trigger factor for RA, the published studies vary widely with respect to study design and methods used for the diagnosis of RA and PD, which in turn make it difficult to ascertain the association between RA and PD. The clinical designs most commonly used were case control and cross-sectional studies, and the main concern was being the criteria used to define control subjects. The fact that RA and PD have similar physiopathologic mechanisms, such as chronic inflammation with adjacent bone resorption, has led some authors to suggest that RA and PD are a variety of the same disease. Both are chronic inflammatory reactions in an immunogenetically susceptible host. However, PD has a well-recognized bacterial etiology, while on the other hand, the cause of RA is unclear. It has been accepted that many different arthrodogenic stimuli exist that could include exogenous infectious factors or endogenous substances such as connective tissue proteins and altered immunoglobulins, resulting in an autoimmune response. Periodontal bacteria are able to activate immunological responses by different mechanisms. One such mechanism includes the ability of P. gingivalis to produce a peptidyl arginine deaminase enzyme, or PAD, which leads to citrullination of host proteins and the production of putative autoantigens. At the same time, antibodies against heat shock proteins of P. nigricins and Prevotella intermedia have been found in synovial fluid of patients with RA, possibly triggering an immune response. It has also been reported that human leukocyte antigen, or HLA, genes are directly associated with RA and PD. These powerful risk factors for both diseases further suggesting a close connection. There is a little bit more that I want to read, but Charissa, at this point, do you have any thoughts or you want any clarifying points about what I've already read?
No, I mean, I get overwhelmed because I explain this to patients a lot, where, I explain what the oral pathogens do in our mouths is basically set up camp below the gum line, right? It's warm, moist, dark. There's not a lot of oxygen down there. So you've got those, anaerobic bacteria. That's a perfect place for them to hang out, set up camp. They literally build community. And in that process, they secrete toxins, and that initiates the immune response, and that initiates inflammation, and that, starts the whole process, that inflammatory cascade. And obviously, we'll see the bleeding, and now there's interaction between these pathogens and the full body. And, basically what these articles are saying, and what I explain to my patients is, PG does the same thing in the joints that it does in your mouth. It sets up in those joints, just like it does under the gums. It builds community, and it initiates that inflammatory response that starts to then degrade the bone. And, that's kind of the layman's terms way to explain this. And this is why I wanted to make another point. This is why, and I had read as we were preparing for this, that one of the reasons that this is such an issue with patients that are having joint replacement. So the synovial fluid is normally there as part of, obviously, to lubricate the joints and protect the joints. But when a patient has a joint replacement, that synovial fluid level is lower. They, take some of that out as they replace the joint, and it hasn't built fully back up yet. So they're more susceptible to infection in those areas. So that's part of that I just thought was interesting that I wanted to share. But and I know we're going to get into this in a minute too, but I just think in light of where we're at on a scientific ability level, and I'm going to speak to salivary testing here, I think we do a disservice to our patients if they're coming in for clearance, or if they have strong family history of autoimmune disease or arthritis, or if they themselves are dealing with an autoimmune or an arthritic condition. I think we've got to be salivary testing. And I think that's imperative before we even get in there and really start wreaking havoc. Because in light of this information, we could be exposing them to a lot more of those pathogens than what they're already experiencing. Now, if they're coming in telling you, hey, I'm brushing and flossing and I'm seeing bleeding, then they're obviously exposing themselves to that. But I think just salivary testing, first and foremost, makes sense for us to really see, do we have a high levels of PG? There's a lot of studies that are showing that AA plays a big role in this as well. I know you just mentioned, the Prevotella intermedias plays a role. So I think the responsible thing to do is start with salivary testing and know what we have there. I think the other thing we've got to do, we've got to help our patients understand, because there is still this mentality that pink in the sink is no big deal.
Right.
They come in and say, oh yeah, I have a little bit of bleeding, and it's no big deal to them. And I've been telling my patients here lately, look, my goal is I want to practice prevention versus reaction. If you're coming in here and you're telling me that you're seeing bleeding at home, we've got to be reactionary to that. I would rather, let's get you in a place and doing the home care that's necessary and seeing me on the intervals that are necessary and doing these necessary therapies so that we don't have any bleeding. Because so what the research is showing us from all factors, whether we're talking autoimmune and RA or heart attack, stroke risk, or Alzheimer's risk, or pregnancy complications, like all of it, the mouth is the gateway to our body. We've got to make sure that we're keeping these pathogens levels as low as possible. And so I just think that, our patients need to be hearing this more and more and more from us, and patients are starting to come in and they're going, oh yeah, I read an article, heart health is a big deal. And they know about that, but they don't necessarily know about this. And so I do want to share, and I know you've got a patient to share about too, but I had a patient who came in and she was having an arthritic flare in her wrists, and she is a golfer and that's kind of her passion. And she's like, yeah, I actually haven't played in a while because I've really been hurting. And so when I got in her mouth, I realized, ooh, she's got a lot of inflammation too. And we did salivary testing. I said, I don't want to get in there and disrupt anything today. Let's see what we're dealing with. We did actually go ahead and scan for periotrace. And then when we got her results back, she was like teeming with all the things that we didn't want her to have in there. And we did systemic antibiotics, and she came back to get her trays 3 weeks later. And she's like, just with taking those antibiotics, I am feeling so much better.
Oh, wow.
Yeah.
That's
And then
big.
obviously, as we went through therapy, by the end of that, she had a very marked improvement with her joint pain.
Mhm.
So, I mean, what a gift when we get to really, really help patients with their overall health. But I think we've got to go in that headspace when we're treating our patients and really, playing the detective game to really look and see what's going on in there or what could be happening. And I just think salivary testing is kind of should be our number one front on that.
Yeah. Yeah, for sure. So now that we understand kind of how the perio-pathogens can produce the enzymes, which stimulate citrullination of the arginine, which can lead to production of the autoantigens and the autoimmune response, let's talk about how we can modify the oral microbiome to minimize or eradicate these pathogens. So one is what you just mentioned, which is salivary testing. And you and I know this is an invaluable tool for determining how to proceed with treatment, especially in an immunocompromised host. Oftentimes the result of that salivary testing is, the recommendation will be a combination of oral antibiotics, clinical disruption of biofilm via SRP, and the use of subgingival air polishers, as well as adding probiotics and fermented foods into our patients' diets. And I do want to read a little excerpt about probiotics and fermentation for patients with RA and gut microbiome.
Yeah.
The link between this is from an article called Probiotic Supplementation for Rheumatoid Arthritis. It was published in 2021. I'm looking, it's the Frontiers in Pharmacology Journal. The link between gut dysbiosis and RA has expanded the interest in investigating the modulation of the gut microbiome as a possible adjuvant therapy for disease prevention and treatment. The increasing evidence reporting the positive effects of probiotic bacteria in animal models of arthritis has been leveraging the desire to transfer these benefits into clinical practice. However, only a small number of studies addressed the role of probiotics in the management of RA on human subjects, and to the best of our knowledge, no human trial has investigated the role of probiotics in a preventative approach. Research in this field is still in need of high-quality studies with larger sample sizes and longer treatment durations to ascertain the exact benefit of this promising treatment for RA patients. Probiotics supplementation in RA seems to have no clinically significant adverse effects, but further research is needed to get a solid basis concerning the most appropriate strains for RA patients. As of now, LKC seems to be the strongest candidate, and its potential effect on gut microbiome and immune system could be further explored to achieve new insights on promising therapy for RA patients. Moreover, fermented foods may be a possible alternative to probiotic supplementation, as some of these foods and beverages are known to be probiotic carriers with potentially similar health benefits. As the current body of evidence investigating the impact of fermented foods on health and disease remains insufficient, its proposed benefits on the human gut microbiome should warrant future research consideration. Additionally, so that says basically, it's vague, we're unsure, but we think that this could potentially be promising and it warrants more research. But I think that just generally kind of what we know about gut microbiome and the fact that microbiome in your mouth is all connected, and how, something like SIBO or leaky gut can significantly impact the rest of your body. And for me, anytime I've done an elimination diet or I've changed my diet and added probiotics and that sort of thing, I will notice physical changes, not just in my gut, my digestion, and it'll be like a minimized lethargy. It'll be like more energy, better sleep quality, so many physical things change for me. So just from an anecdotal aspect, I think this is one of the easiest things to underutilize or under consider, but I'm glad that the door is kind of opening for us to research, okay, how can we then, if we understand how these pathogens are impacting or how they can stimulate an autoimmune response, what tools are in our toolbox to be able to kind of fight them. I think this will probably be one of the first avenues that are the easiest and most available to our patients to use. So that's what got me excited about seeing an actual research article, at least kind of considering this.
Right.
The fermented foods and the probiotics.
Yeah. Well, anytime we can do something that in my brain is more holistically charged makes the most sense to me. And on that note, I want to plug two different companies. And we're not getting any backing for this, but these are just two different companies that we're using. that make a lot of sense to me. One is on the vein of probiotics. So I don't know if any of our listeners have ever looked into Probiora Health, but we have oral probiotics that we prescribe for our patients. And obviously this is not gut bacteria. This is oral, good, healthy oral bacteria. Mm-hmm. And how I explain this to my patients is I implement this a lot after doing scaling and root planing. And what I explain, this is just kind of the generic way I explain this to patients is, hey, I'm going to go in here today and I'm going to clean a lot of the bad guys out. I'm not actively sterilizing anything. So I know that I'm leaving a few of the bad guys behind because this is not a sterilization technique. But what I am doing is disrupting and removing a ton of them. Mm-hmm. So bacteria are a lot like people as far as how many can fit in a space. So if we had 100 people in this room and I cleared out, 75 of them, now we have more room. So either the 25 left are going to quickly start replicating and duplicating and filling it up again, or we can have some more of the new good bacteria come on in mm-hmm. and take the space up. And now we're actually, flipping that dynamic around to where we are more overpopulated with good and healthy. Mm-hmm. So the concept is after I'm going in and cleaning and disrupting the bad bacteria out, I want you to reinstate the good bacteria. And it's a tablet that they put in their mouth once a day. They just, suck on it, let it kind of disperse around their mouth, and those bacteria have a chance to move back in. It's a lot like what happens with probiotics for our gut, but this is specifically for the oral environment. So that's just one thing to think about as an opportunity. The other thing, and I just want to hop back for 1 second, I know there are a lot of different alternatives out there for salivary testing. I do want to encourage our listeners to look into HR5. It just launched this year, 2020. It's through Direct Diagnostics. We in our practice are getting ready to change over here in the new year. I'm in the process of getting it all set up. But it is a lot more cost effective for your patients. And the turnaround time is 2 days. You'll have a result in 2 days. So, if that's something if salivary testing is something you haven't yet gotten into, I'm going to encourage you to look at HR5 because it makes a whole lot of sense to me.
Love it. And we'll be investigating that this year too. We use MicroBlink DX right now, but I think that we're going to look at that too.
And I do want to say we use oral DNA, and we're going to keep oral DNA on our plate. I love it. There's a lot of things that oral DNA offers that the HR5 doesn't quite yet. Mm-hmm. And they are also created by it's Dr. Tom Neighbors. So, but yeah, it's if you're just getting started, I think that's the place to start.
So I want to talk about one of my patients who was experiencing some chronic joint pain and just kind of like what we found on her and what the recommendations were. And I want to give an example of what like salivary testing for this person looked like, just as an example, so that you can see kind of how this process goes. So I had a young patient, she was 26 years old, who came back in after 2 years of being away from the dentist. She was experiencing unexplained joint pain. She didn't have an official autoimmune diagnosis. Very healthy, otherwise, no allergies, no surgeries, wasn't on any medication. She was taking, oh my gosh, what's it called? When you're trying to get pregnant, you take
vitamins, prenatals. Yep.
Just prenatals. But so she was 26 years old, very healthy, except had this unexplainable like joint pain, and also had a history of 2 very recent miscarriages. And she hadn't been to the dentist in 2 years. So her chief complaint was just, I'm overdue. And clinically, she had really pink stipple gingiva, localized rolled margins, no radiographic calculus, very mild, very localized evidence of radiographic flattening of lamina dura, but generalized, the crestal bone was still 1 to 2 millimeters from the CEJ. So she was very much like healthy attachment, no recession, like, basically gingivitis scenario. And her probings were 3 to 6 with generalized moderate bleeding on probing. So that was already, kind of a red flag to me. Medical history wise, the red flags were obviously joint pain and the 2 miscarriages on this very young, very healthy patient, right? And then probings with moderate BOP were actually the second like red flag, because when I'm clinically looking at her mouth, I wouldn't expect to get probings like 5 and 6, even around her 3rd molars necessarily. And it was a lot of, gingival hypertrophy. And it was in the lingual surfaces of 2nd and 3rd molars, but still there's inflammation, there's tons of bleeding. It was very suspicious. So I recommended we do salivary testing. I scanned her for periotrays, did a gingivitis debridement on the same day, and then did periotray delivery in 1 month from then. And the patient opted not to do oral antibiotics due to the fact that she was trying to get pregnant still, but just disrupting the biofilm and putting her in periotrays has been very, very effective for her. I've seen her several times since then, and her perio or her gingivitis is very, very arrested at this point in time, just with the periotrays. But I wanted to talk about just the outcomes of her salivary test because it was interesting. So she tested above threshold for 8 of the 11 periopathogens. And of course, 3 of them were the ones that we just talked about that go hand in hand with arthritis, the Prevotella intermedia and the PG and Prevotella something else. So the recommendations for her were scaling and root planing, or just removing the plaque and debriding the compromised tissue. And it said that a few of her periopathogens may be refractory to this treatment. This patient hasn't indicated any allergies, so the antibiotics that were recommended were amoxicillin 500 milligrams 3 times a day for 8 to 10 days, and metronidazole 500 milligrams twice a day for 8 to 10 days. As adjuncts to SRP, of course, they recommended subgingival doxycycline hyclate and chemotherapeutics, went through periosurgery. But I always like to read, like, okay, what antibiotics are recommended, and is this like a scaling and plaque disruption? It's always pretty similar. But it's very interesting just to see kind of what periopathogens were over threshold and how this system was recommending treating them just in a basic way, you know. And I'm glad that we got some of this under control. I don't believe this patient is pregnant yet, but I haven't seen her since last recare, so it's possible that she is. But I'm looking forward to seeing kind of like, all right, in the future, like what came of this, and were we able to help her on her like fertility journey basically, and how is her joint pain, and kind of like follow back up with some of that stuff.
Well, that was one of my questions, was going to be, have you seen her enough? Has she had any comments as far as, lower joint pain since you guys have treated?
Yeah, that's a great question, because I think that after I delivered periotrays, I think I did 1 check and 1 recare, and I haven't seen her since then. So I don't know if she's just like due, or if she's overdue, or she fell off the wagon or what, but I'd be interested to know that too. I don't think that I ever followed up with that.
Yeah.
But I need to, obviously I want to.
Yeah. Got it.
Yeah.
Well, and I think, there's another avenue here that I just want us to kind of think about, reaching out to your local, doctors that are sending letters for clearance.
Mm-hmm.
And instead of just, responding back and signing that clearance letter, maybe just, kind of formulating a letter to that doctor saying, hey, I know you sent Mr. Jones over to us for clearance, and, we're happy obviously to clear him or to not clear him. We need to treat him, whatever. But we also want you to know we're here for all of your patients, and we actually perform salivary testing that will tell us very specifically whether or not this patient has those pathogens on board that could potentially, affect your outcomes. So we would love to partner with you in helping making sure that these patients get, the right assessment and the right treatment to make sure that we're ensuring your outcomes, not only, because they've got a license to protect, and they want to make sure that they're doing the right things and helping their patients see the right and best outcomes. So that's just food for thought of something that we could be doing, again, to kind of build that community with the doctors around us.
Yeah, and hopefully the number of providers who understand the value in that for them and for the patients is growing, as research evolves and as research comes out about oral systemic link, and just more and more and more like myriads and piles of new evidence, like supporting, we're all a part of it and we play a huge role in the outcomes, body outcomes, basically.
Right.
Hopefully there'll be a lot more advocates and people who are willing to partner, like we talked about with Laura.
Yeah, and Dr. Pritchard. Yep.
Yeah, exactly.
Yep, for sure.
Do you have any final thoughts, Charissa, about this topic?
I mean, honestly, for me, it's just more a reminder of the weight that we carry and the gift that we have in getting to really impact patients' life and their quality of life and their long-term outcomes. And I think it gets very easy to view this as, oh my gosh, it's another thing I have to pay attention to. And, oh, it's another But what I'm hoping is that in the world of hygiene, in the world of dentistry, we are moving into that, like you said at the very beginning, we're treating the whole body, you know, and again, the mouth is the gateway. It starts the respiratory tract. It starts the digestive tract. It has a huge impact on circulatory system. I mean, it really is the gateway to everything. So we have to be just really intentional investigators for every single patient that's coming through. And I think if we'll do that well and learn to communicate well and really get ourselves familiar with the research and the knowledge that's out there, I think we're going to see this build more and more and more to where patients are coming to us saying, hey, I want to make sure I don't have anything going on in my mouth that's going to put me at risk because I see what's happening out there.
Right.
Yeah.
Right. Awesome. Well, things to look forward to and things to influence in our laboratory on a daily basis. We are so thankful to have you guys joining us today. Please remember that we've got our summit coming up in Nashville, June. Is it 3rd and 4th, Charissa?
It is.
3rd and 4th in Nashville, 2022.
This year, we're in 2022 now. So
Right.
Come see us this year. We would love to connect with you.
Come see us live. We hope that you're able to make it. And if you would like any additional information, go to bulletproofsummit.com. There's information about what tracks will be covered and how to register. So we hope to see you guys there. Have a great week.
Bye-bye, everybody.